and thank you all for attending. On behalf of the American Heart Association and the Center for Health Technology, we're really excited to have this webinar on women's heart health. And with that, I'm going to kick it over to our moderator, Dr. Erin Michos.
Hi, welcome everybody. I'm Dr. Erin Michos. I'm a cardiologist that focuses on women's cardiovascular health and preventive cardiology at Johns Hopkins University. And I'm really pleased to be the moderator today for this special Women's Heart Health webinar sponsored by the American Heart Association, focused on health technology solutions for women. And today we have three amazing panelists, so we'll look forward to their comments. So I want to welcome our panelists and have them introduce themselves some more and tell us a little bit what they do and how they got into health tech.
My name is Dr. Suzanne Steinbaum. I am by training a cardiologist, and I started 20 years ago. I've run and been the director of women in heart health programs in 3 major hospitals in New York City. And I left 3 years ago when I decided to start a technology company that has created a really innovative software for women's cardiovascular health, wellness, and prevention to really educate and inspire women to take care of their hearts, and for primary care providers to identify risk early in women, to treat and diagnose and provide lifestyle interventions before a woman has to get to a cardiologist.
Great. And Jenn Roberts.
Absolutely. I lead our employer health strategy team at Hello Heart, and my background is in clinical research. I'm an exercise physiologist. And when I first started doing cardiovascular disease prevention research, everything was in person, everything was on paper, it was very slow. So it's just been kind of an evolution to be at the point where we can really offer digital solutions to people to help them progress on their wellness journey.
And thank you so much. And thank you to the American Heart Association for always bringing forth such important topics. Hi, everybody. I'm Fran, Ayalasomayajula. I am the president of Reach Healthcare as well as Happy Mama. Reach Healthcare is a global social impact organization, and one of our main programs is Happy Mama, which is a technology-enabled doula practice. It's a full spectrum practice, which we're really excited about. By way of background, 30 years in the healthcare industry, started my career as a community epidemiologist and public health professional. For many years, I was the global head of population health for Hewlett-Packard. I've worked for many organizations, inclusive of Bristol-Myers Squibb and many others, where around the world I was focused on e-business strategies to really help improve experiences for both patients as well as providers. And where, technology has essentially been at the core of what I have done, really kind of comes back to, as an epidemiologist, working with software and statistics and databases to help us in identifying, in the early days, identifying where a lot of the hot pockets were, if you will. And then later on, even in the focus as the director of heart disease and stroke prevention for the state of Tennessee many years ago, again, leveraging the technology. It's something that I think I never got away from. And as a result of that, my career has been focused on that, even as the a board member of the Preeclampsia Foundation. The foundation, as we're focused on prevention of preeclampsia, leverages technology and the work that we do to help improve the lives of women during prenatal as well as postpartum.
Great. Thank you. And again, we're part of the motivation behind having webinar and other education programs like this is that, we have still this problem with cardiovascular disease being the leading cause of death of women in the United States, as well as globally. And actually, despite several decades of progress, cardiovascular disease is on the rise in women as well as in men. But if you look at the fastest growing rate of change of heart disease death is actually in middle-aged women. So there's definitely a urgent need for women to be able to take more ownership and help take a proactive role in their own heart health. We know that there are a lot of disparities with women patients being less likely to be treated with guideline-directed medical therapy, and there's also delays in diagnosis and recognition of cardiovascular disease in women, which can present sometimes a little differently than it does in men, and women can also have unique risk factors for cardiovascular disease that related to pregnancy and menopause that men don't experience. So in that background, we've seen a lot of success of awareness campaigns or movements related to diseases like breast cancer, but perhaps maybe not the same efforts around cardiovascular disease. There's been actually surveys from the American Heart Association that have shown sort of actually a decline in awareness of women patients that heart disease is their leading health threat. So we're losing ground. And so my question for the panelists, we can start with Jenn, is how can we use health technology to promote awareness of cardiovascular disease risk factors in women?
I think that's such an important issue. And to me, the number one statistic that sticks out is that women are 2 times more likely to die of a cardiac event than men. And that's just wrong. That's something that needs to be changed. And I think using technology, we can really get over some of those barriers to care that you were mentioning earlier, Erin. And in particular, Hello Heart is working on a campaign for Women's Health Month that is, if you feel something, say something, and to not dismiss those symptoms. So part of the piece of Hello Heart's technology in their app is a symptom checker that's based on biological gender, knowing that symptoms can be slightly different for men and women. And in particular, women can feel more vague and not as concrete as the traditional heart attack symptoms that you often see in men. So giving women the reassurance that there is something going on and helping direct them to care through that.
Great. Fran or Suzanne, do you have anything to add to that?
Absolutely.
Yeah, please go ahead, Suzanne.
Sorry, Fran. I think one of the most important things we have to realize is that this problem comes from 3 different places. We have the research lag that really hasn't, before 1984, there was 20 years of a girth of research on women's hearts. So we're still catching up from the research side. And then when we look at that research, how it gets implemented into clinical practice, it takes about 15, 20 years for that research to hit the clinician to be implemented. Then we have to look at the women themselves. And as you mentioned, the women are not aware. When we look at the big picture of this, the risk analyses that are typically used really miss women, especially those women less than 65 years old. It doesn't even identify them as being at risk because it doesn't talk necessarily about their unique risk factors, like adverse outcomes of pregnancy, like psychosocial issues, like depression, anxiety, stress, things like that. It doesn't talk about all of the relevant factors that matter to that woman and increase her risk. And when we think about what we see in movies or television, it's that overweight man, blue in the face, clutching his chest, that Hollywood heart attack. And we all talk about that. So we have to reframe the story and make these issues connect to the women and say to the woman, it's not that, it's you. If you have a heart, you are at risk for heart disease because we all are, because we know that heart disease is the #1 killer of women. And I think what technology can do is switch this unconscious bias that goes on throughout the medical system and goes on throughout the community of women who don't believe it's her issue. We've got to change the risk analysis, and we have to make this issue matter to each and every woman.
Yeah, I really echo the sentiments of both other panelists. I think that one thing that we failed to mention is a lack of investment. We're not seeing the investment where it needs to be, and equal to the research, health education was one of the real factors that played a significant role in drawing the awareness from a public perspective and from communities. Equally, really challenging and encouraging providers to participate in those education awareness campaigns. And that's something that we need to continue to do today. What's, I think, refreshing about technology is the ubiquity and the opportunity that it drives forth really low-cost measures to reach a broader, more diverse population of individuals. And that's what I'm looking really forward to us being able to do more with organizations like the AHA to be able to accomplish that.
Great. So we've already sort of touched on the unique risks that women may experience related to adverse outcomes of pregnancy. And unfortunately, maternal mortality is on the rise in the United States, and cardiovascular disease is one of the leading contributors. And maternal morbidity and mortality, unfortunately, disproportionately affects women of color. And so I wanted to ask our panelists, and starting with Fran, about how technological advances can help improve treatment of women's heart health, and maybe some comments, particularly around pregnancy and preeclampsia, and how technology can help reach these women after an adverse pregnancy outcome and make sure they're not lost for follow-up.
Well, I think the biggest thing is really, again, as we've talked about it, signs and symptoms and awareness. So there, I'd like to speak to Happy Mama, but I want to be cognizant of all the amazing technologies and platforms that are out there that are available to help women better to monitor their health during their pregnancy, and the role of multidisciplinary care teams and helping facilitate that education. But equal to that, quite frankly, if I ask you if you have a thermometer in your home, everyone raises their hand. We've all got thermometers, but the truth is we should all have blood pressure monitors as well. And, for women in particular, that's very important, and being able to reduce the cost, really lowering the barrier to making that type of investment is something that we need to spend more time on. And technology makes it possible because you see sort of this integration of these, monitoring devices, along with tools that help to support the communication directly from the individual back to their providers, as well as providing for health literacy. It's inefficient even to say, let's monitor our heart health, but not really providing women with the tools that they need to understand and, what the data means, how to interpret it, and how to go about behavioral modifications that are appropriate. And this is where, again, as I emphasized before, really technology has an opportunity, and this is where we leverage it to really influence that. And one really just quick way that we have gone about that is incorporating the care plans of the American Heart Association for lifestyle, as well as for heart health, directly into our platforms for pregnant women. So as we begin to talk to them about their prenatal as well as their postnatal journeys, we incorporate that educational material and add additional resources for them. And it's amazing to see how it helps to really transition them in terms of choices that they may not have previously made because they really just weren't aware.
Thank you. And Suzanne, do you have anything to add about how you see technology and how it can advance and improve treatment of women's heart health?
Yeah, I'd like to just touch a little bit on what Fran just said. And it sounds like, Fran, technology has been a huge part of your entire career. I think for many of us, we didn't really jump on the bandwagon until COVID happened, when we realized that technology was a necessity. And all of a sudden, we had to communicate with patients remotely. And for me, as a practicing cardiologist at the time, I never did a telemedicine before. And so that basic thing that seems so, we're on a Zoom call right now. I never did that before all of this. So these basic issues, now we can communicate, now we can educate. And for women, the education has not been there. Pregnant women think they have an adverse outcome of pregnancy, they give birth and they're better. They're solved, the solution is there. Well, by 10 years, those women are now at risk for heart disease. And so we have to grab those women and really make this education matter to them. What does it mean to eat better and exercise? Well, now you have a baby and you might want to get pregnant again. And here are the steps that you need to take. But now we have another issue. We can communicate, as you mentioned, with the provider through remote patient monitoring, not only blood pressure, but are you exercising? We can use heart rate monitors. We can use all of these tools to really enable not only behavioral change, but ensure compliance. And when it comes to lifestyle intervention, We all know behavioral change and compliance are two of the toughest things. When we look at the healthcare system, doctors spend about 18 minutes with their patients. We're certainly not getting compliance and behavioral change through that model. And so we can use technology to really change our patients' lives in a much more effective way than the old model, which happened in the confines of the office, the doctor's office, where there was not enough time and not enough room to really have an impact.
Thank
Fran,
you.
I love what you said about the blood pressure unit becoming the new thermometer. I'm saying that also, so I'm glad it's not just me. And maybe we can create an echo chamber about that, especially for women as part of this webinar. One thing that really struck me is that about a year and a half ago, I was doing a presentation with someone from the CDC, and they were actually doing a call to action for employers, which is pretty uncommon actually. And that call to action was to get blood pressure monitors in the hands of your employees, make sure that it's an FDA cleared device and that they're able to send those results to their provider electronically. And I think, Suzanne, you're kind of hitting it home there, 18 minutes. And I think that's probably generous amount of time that the provider spends with the patient is really not enough to enact that change. And to be able to provide, here's what my blood pressure has looked like over the past week or month, here's any arrhythmias or regular pulse that were detected as well, then empowers the patient with the data that they need. But it starts with the individual person. And, we can't fix the entire healthcare system right now. And AHA is making remarkable strides toward helping to battle this epidemic of heart health, in particular for women. But if you can actually then empower the individual to raise their hand and say, I think something's wrong. I want more advice. I want more treatment. I want a second opinion. So they don't get dismissed from the doctor's office in the throes of an actual heart attack. I mean, we've just in the news, it's almost every single day you're seeing an article right now about someone who went in for care and was sent on their merry way and in fact was having a heart attack or had a heart attack. That needs to stop.
Yeah. Well, one of the challenging questions, though, is related around the digital divide and whether there's the same access to all to health technology solutions. And so I wanted to touch a bit about specific cultural and social demographic factors that not only increase the risk of cardiovascular disease and outcomes in women, but also, can health technology help address those factors? Or is health technology creating a bigger divide and lack of access? So I'd love, this is a challenging question, but I'd love, I can start with Fran again, what you think about, since you work in populations with that of disparity.
Yeah.
And
it's an interesting question, Erin. And as you were posing that question, it made me think back to a very personal incident that actually just happened about, I think it's been maybe not even 6 weeks ago, or not even 6 weeks ago, barely just over a month. My father-in-law had passed away, and we were in India for several weeks. And during that time, we decided that, my mother-in-law had been spending so much time taking care of my father-in-law that she had not been taking care of her own health. And ironically, when I took her in to get just, a routine checkup, we were sitting there, everything was fine. And all of a sudden she says, my head is hurting. And I thought, okay, let's get you some water. And then she drank some water, she felt a little bit better. And then the next thing you know, we're sitting there, we're reading our magazine, waiting to be seen. And she falls over. And then it was revealed that this was not the first time that this had happened, that she had a couple of these episodes in the past. And it was very startling. And particularly to find out that it had been happening and she just dismissed it. And her remark was, well, when it happens, I'll just sit really still and then, I'll get some water and then I'm fine. And I'm like, no, you're not fine. So the next thing I know, we're in this whole whirl of visits with cardiologists and doing stress tests and all kinds of, echocardiograms, all of these angiograms, all of these things are happening. And one element of this, of course, was that, thank goodness that when she did have an episode, she presented at a time that she was in a clinic so other people could see it. But what typically ends up happening is when you say, oh, this is occurring to me, well, you're stressed. Your husband just died. And literally, this is one of the clinicians is saying this. And I'm like, no, get a monitor on her. Let's take her home. Let's use the technology. Now, my husband, my brother-in-law, and myself, we all use all these gadgets and gizmos to monitor our health. And these things were yet completely new to her, right? They were absolutely foreign, new. But the moment we introduced it, even at her age, she was willing to embrace the technology. I was comfortable being able to come home weeks later, knowing not only that I settled her in, but that we had integrated a technology into her life that helped me, helped my husband and the rest of our family, along with her, feel as though we had put in place the tools that she needed and that we needed to reassure and to make sure that her health was being properly monitored. Aside from this, all the other things that we talked about, modifications in lifestyle, I love, we call it sambar. It's a beautiful soup, but it can be too high in sodium. And these things had to change. And going through this whole educational process and being able to use technology just to do simple things, even to find heart healthy recipes, which might seem really simple, but the point that the technology can bring us closer to resources that are necessary and making the modifications that we all know are necessary is essential. And so I think that we are seeing the costs come down on the technology. We are seeing that as a people in general, everyone, while we're not all digital natives, we as long as we have the willingness to embrace embrace new things and learn, we can make a difference. We can make the difference within heart health for everyone. And I believe technology truly can be at the center of that. And I can't help but to have shared that, personal experience, because it's a prime example of where I've personally seen it work on top of all the work of working with hundreds of and thousands of women around the world, where we've been able to successfully make it work for them in terms of reducing the number of hospitalizations as a result of preeclampsia. So I hope it wasn't to take up too much time there, but I really wanted to share that.
Oh, thank you. So Jenn, as with Hello Heart, are there any free apps, or how do we make health tech more accessible to sort of the broader population, particularly the ones that might be the most, underserved and vulnerable?
To me, it's really interesting. If there's one positive thing that came out during COVID, is that we did actually have to start using technology if we weren't using it before, just like Suzanne was saying. And telemed has significantly increased. Employers are already offering all kinds of app-based solutions to help with disease management, chronic condition management, general wellness. And I think, what's surprising is at Hello Heart, our average age is 51 years old of our users. So you on one hand think, an employer's like, oh, this may be something digital is if I've got a younger population. But in fact, people of any age can use it. One of our oldest users is 101 years old. And I think that that's really a fallacy and puts people at disadvantage, because one of the number one barriers to care is actually access, whether it be cost, proximity, different things like that. So if you have a digital tool in your hand and it's offered by the employer, so it's no out of cost pocket, and you're using the appropriate health literacy and tech literacy levels, you can get over so many of those barriers to care with one piece of technology, and people will use it and they can improve from there. And in particular for women, I think, because as we were talking about earlier, symptoms are often dismissed, or we just keep going, put that aside. We're busy taking care of other people in our lives, to really reinforce that message that there is something that's going on here. You should see a provider. Do you need help making an appointment? Let me help you find one. Really encouraging women to seek the care that they need at the appropriate time.
Yeah, I do think there's, increasing access. It does seem statistics that 90% of US adults do have a smartphone. So it's actually pretty high prevalence. As someone who does telemedicine, there are still some challenges. Not everybody has access to internet or a stable internet. So sometimes the video telemedicine doesn't always work. And then they try to switch to the phone, and whether you're getting the same kind of comprehensive, just by audio, you can't see the patient, see how, whether they look well or not well, or so there can still be some challenges that we're overcoming. But it is exciting that we're be able to reach more populations, particularly rural areas where coming into an academic center like Johns Hopkins might be a long drive, and they have a special condition, and being able to do a telemedicine and kind of reach a broader population. But I wanted Suzanne to touch on this too. But I also we've been talking a lot about financial and social economic barriers, but I also was hoping you could address depression and anxiety and some of those factors and how they influence the uptake of technology, or how technology can help with those factors.
About 4 days ago, Dr. Vivek Murthy, our Surgeon General, made a statement that there is a new epidemic of loneliness in this country. That, in fact, this epidemic of loneliness is equivalent to smoking 15 cigarettes a day. Now, when you say that to a cardiologist, they're like, come on, that doesn't make any sense. But it really sheds light on this really huge connection between the mind and the heart. We know women with depression, about 20% of women throughout their lifetime will experience some form of depression, which increases the risk of heart disease 2 or 3-fold. And when we look at what causes depression, let's focus on loneliness for a second. One of the things that we've been able to accomplish, the name of my platform is Adesso. And Adesso, I say the language of Italian, of romance, the heart of love, it means now. And if the time is not now to change all these statistics, I don't know when it is. And I keep focusing on this issue of now. How do we really address everything that's going on in a woman's life? That access to care piece, who she is, the caretaking piece. It's a big deal for women who are taking care of children and parents. This is a reality of the sandwich generation. And this idea of loneliness and isolation, we can use technology to create a community, to have people online with the same issues, having the same discussions, and really connecting on a deeper level through technology. That was what social media really became ignited around. And we can ignite a movement for women to connect about their heart health, can connect about what it means to be a mother, a caretaker, a friend, a wife, a sister, all of the issues on a platform, on an online community that can really take away that loneliness piece. And I don't think that was something that any of us intended on when we entered this arena of really being able to connect with patients. But now we have a place where patients can connect with patients and women can connect with women. And we can really get rid of this issue of loneliness that I think we have to pay attention to, the same way that we paid attention to smoking.
Well said. We can't talk about cardiovascular health without talking about mental health. So that's really important. And I'm glad that technology can help overcome some of these challenges. I did want to move into about how technology is sort of developed. So we already talked about how cardiovascular disease can be a little bit different in women, present a little bit differently, also with unique risk factors in women, such as those related to adverse pregnancy outcomes. But what about technology itself? Do we think there's gender biases in how technology is developed? And should technology be developed with a sex and gender lens, such as unique considerations with developing technology specific for women? So Fran, I'll let you start off this. What do you think about technology being specifically designed for women? Is there a gap, and is this something that should be done?
Well, there has been a gap, but I think we're starting to see it close with, sort of the rise and expansion of femtech. When I think back to the first wearable blood pressure monitor, without naming names of product manufacturers, I had one of those devices, right? So I could test it out, see how we could use it with older adult populations in particular. And it was clunky, chunky, and heavy. And it was something that I wouldn't want to wear. And when we showcased it, one of the things I do work is with, we bring together tech groups of older adults to get their sentiments on the device. Those weren't my words. Those were the words of some of the female participants in the focus groups that we had, that clearly the technology was not designed for them in mind. What was it designed for? It was designed for the picture that had already been sort of selected by the marketing team of an older gentleman fishing with his grandson. So yeah, I think that that's a problem. But then you see the reverse of that with femtech as an example, where brilliant technology is being used to integrate the technology directly into garments, right? Into brassieres as an example. That's huge. To create those, to be that resourceful and to take into account the day-to-day lifestyles of women is important.
I have a good example of this. So for some reason, a wonderful reason, women do slightly better on the Hello Heart platform than do men. Both are achieving nice outcomes, but the women are slightly better. And I really wanted to understand that and why that was. And so when we looked at usage of the app, you see men start to take their blood pressure, maybe they share a report, maybe a few months later they add a medication. So they follow this very linear path to unlocking all the features of the app and becoming a super user. Whereas women typically jump right in and start using all the features and become much more fluent in the app more quickly. And then that impacts them having the better outcomes slightly and faster. So I think, you're really asking a thought-provoking question, Erin, related to that. In terms of design of technology, I think it's interesting where prior, maybe it was more men working in tech designing these programs. And now we're seeing that, it's getting more equalizing out. It's not quite there yet, but absolutely, it's important to consider gender and what's important to the individual, really for any of these programs in technology, because there are differences. And if you can address those differences and really customize and curate an experience that's going to be meaningful, that's what's going to drive engagement and help people find their intrinsic motivation to make those lifestyle changes. They're the same no matter what gender you are. It's eat better, move more, stress less. But the direction that you get there to helping individuals find that motivation to change can be different.
Erin, this is my obsession, so I have to just jump in for a
Please,
second.
yes.
I don't think anything's been designed for women, really, very much. And so let's talk about this. As Jenn, as you mentioned, what is your motivation? We talk about our now. What is your now, your reason? And here's the reason we talk about that. Women, and we alluded to this in our conversation, women tend to put themselves last. Everything else matters before them. And unless we really frame heart health as part of the importance of their life, a lot of times women don't acknowledge the need for them to make behavioral change, to check their blood pressure, to even do these things, unless they're given the tools for a reason. So how do we make this matter to women? And I think that has a lot to do with the messaging and a lot to do with the user experience and what it looks like, how it feels. Adesso is the most woman-driven platform for cardiovascular care out there, because it's really focusing on a woman's whole life and who she is at all stages in her life and what matters to her in making these behavioral changes and decision. Very oftentimes I've had people look at it and say, do you have a man's version? And it's like, no. We are focusing on women for the first time. We really want to focus on women's heart health because women are different. And we've known that throughout all these years of Go Red for Women and the American Heart Association.
Yes, women are not just smaller men, so
There you go.
everything should be looked at through a sex and gender approach. And women have unique differences throughout their lifespan. At different points in their lifetime, would have different both risk factors as well as potential needs and how they can use health tech. So great. Well, I wanted to start to wrap up this wonderful webinar, but I wanted each of our panelists to be able to, give one sort of last final key message or takeaway that they would like to say, some important points for our audience. So this is sort of your chance to say everything that you didn't get to say yet. And Suzanne, I'll give you an extra question too, so you can answer that, but you're also a cardiologist like myself. And so I also want you to tell us, what is there one thing you wish more people knew about women and heart health? So I'll start with you to answer that question, and then any other final concluding remarks you want to say.
I think the most important thing to understand about women and heart health is, we alluded to it and discussed it, symptoms are different, and how she looks on the outside doesn't mean it reflects what's going on the inside. I've had so many women walk into my office, as I'm sure you have as well, being absolutely dismissed, sent home from the ER, told by multiple doctors, it's in your head, you're anxious. This conversation is, unfortunately, to this day, consistently going on. I believe that all women need to be educated to learn to advocate for themselves. They need to understand their own personal risk factors so they can communicate with their physicians. They need to know what those risk factors are throughout the lifespan, as you mentioned, because unfortunately our risk analyses do not detect heart disease in women as accurately as they should. But for everyone, 80% of the time, heart disease is preventable. And when we look at that statistic, what it means is we need to start early. We need to start with primary care providers and gynecologists and obstetricians before a woman needs a cardiologist. And as we say at American Heart Association, we have to know our numbers, and we have to really get those blood pressure, cholesterol, sugars, weight to goal. And it matters. Sleep now is part of the essential 8. We know this matters, but I think that it's important for all women to learn to advocate so that they get the help that they need.
Wonderful. Jenn, what would you like to tell our audience?
I would just reinforce for women, if you feel something is wrong, to say something. And if you get dismissed at the provider's office, dig in and ask for more help, because that is the one thing you as an individual can do that can help you on your healthcare journey. Putting that aside, I would say for any employers that are listening in today, I really want to refer you highly to the American Heart Association website. They have amazing tools, resources, and materials that you can get into the hands of your employees and their loved ones as well, to really support heart health, but in particular, women's heart health coming up in May.
I want to just sort of reiterate that in terms of digital technology adoption, some of us, we live in a bubble because we do it every day. And many of the folks perhaps who are watching this webinar as well, are probably living in that same bubble. The reality is that only, 30% adoption in terms of clinical use of the technology. Even in the space of maternal health, as I've referred to, or when we think about the areas the other panelists are in, there's a very small percentage that are actually utilizing the technology. And I think that if we look to the Center for Health Technology and Innovation at the American Heart Association, it's a prime example of multiple organizations and innovators who are out there who are doing significant work. And the results are there, the evidence is there, and the risks are, nominal, if any at all. It's very much worth your time and investment to learn more about the technology. And if you're truly looking to engage in diverse populations, the technology is a great way to go about that, to create for culturally appropriate, linguistically appropriate communication with diverse populations is something that's very much cost effective and doable when we utilize the technology. But today we are only scratching the surface of it, and not because there's a lack of technology. Literally, there are millions of apps that are focused specifically on health. So it's not that it's not available. What it is that we need for more people to recognize the opportunity, the ways in which you can go about easily integrate it even within your clinical workflow. And there are many clinicians like Erin yourself who are great examples of how this has been very successfully done. You don't have to reinvent the wheel. Leverage the publications and that have already been put out about the many applications, whether it's remote patient monitoring, whether it's self-regulated monitoring, use of telehealth. The list goes on and on, all the way through to the use of immersive and virtual therapies and technology. There are many examples of where it has been used very successfully, and you can have similar success within your own practices.
Take the moderator's prerogative by making a comment of myself that I've been really passionate about the importance of enrollment of women in cardiovascular clinical trials. So clinical trials really serves as the foundation of evidence for which all of our guidelines and our recommendations for patients are really all driven by the results of clinical trials. But historically, cardiovascular clinical trials only have had about 25% of women enrolled in these trials. Trials largely consisted of white men, which means that the results of these trials may not be applicable to the diverse patients we take care of every day. So I'm also a research investigator, and I was really honored to receive a grant award from the American Heart Association to be part of a strategic focused research network to study the diversity, the science behind the diversity of clinical trial enrollment. And one of our aims of our grant is to see if we can use digital technology to be able to reach more populations and see if that could be one component to help harness digital technology to increase cardiovascular clinical trial enrollment. And then we have several other aims all about the importance of community driven and community leaders in helping recruit for trial enrollment. So I just wanted to thank the American Heart Association for being on the forefront of tackling this big issue. Well, thank you. Well, I want to thank all of our outstanding panelists for this really engaging discussion. I know I enjoyed my time that I spent with you, and I want to thank the American Heart Association for bringing us all together and for hosting this wonderful webinar. And I hope to see everybody at the American Heart Association scientific sessions in November. Thank you.